afternoon, everyone. My name is Ling-Ya. I'm a HIV case manager from National Taiwan University Hospital. Today, I'm excited to present our study, Rapid DAA Initiation and HCV Treatment Outcomes among people with HIV in an integrated HIV and HCV care program. This is my disclosure. To set the stage, it is important to recognize that people with HIV are key population in the global strategy to eliminate hepatitis C by 2030. In Taiwan, the introduction of government reimbursed direct-acting antivirus or DAAs in 2017 was a major step forward. However, access was initially limited. Treatment was restricted to patients with advanced liver fibrosis, and prescription could only be written by hepatologists. The landscape changed significantly in 2019. In a pivotal policy update, the government removed the fibrosis stage requirement and authorized infectious disease specialists to prescribe DAAs. This change opened the door for a more integrated approach to care, right at the point where people with HIV were already engaged with the health system. This timeline illustrates just how much policy landscape evolved. As you can see, we moved from a highly restrictive model in 2017 to a much more accessible one by 2021. Key changes included removing the requirement for prior interferon treatment failure and later allowing a second course of DAA treatment to be reimbursed. This final point is particularly important as it created a safety net for cases of treatment failure or reinfection. Now, let's look at the context in Taiwan. While we've seen great progress with HCV incidence among men who have sex with men living with HIV falling significantly between 2019 to 2021, challenges remain. Specifically, reinfection rates were still high, estimated between 40 to 82 per 1,000 person year, which is considerably higher than in many other countries. Moreover, our data shows that sexual exposure is the dominant transmission route in this cohort, accounting for 80% of cases among MSM, with less than 4% of cases linked to injection drug use. This trend underscores the need for treatment strategies that not only cure the initial infection, but also reduce the overall period of infectiousness to limit ongoing transmission. This evolving policy and epidemiologic landscape led us to our central research objective. As you can see from the chart, after the 2019 policy change, ID specialists at our center began to manage the majority of DAA treatment for people with HIV. Therefore, we aim to evaluate the impact of this new paradigm. Specifically, we want to assess how rapid DAA initiation facilitated by this integrated HIV-HCV care model affected treatment outcomes for people with HIV. We conducted a retrospective analysis at a medical center in northern Taiwan. Our study population included all people with HIV who were diagnosed with HCV between 2019 and 2024. We established an integrated care program where HIV case managers play a crucial role. We help facilitate the DAA application process, coordinated care between ID and GI specialists, and provide essential adherence counseling. Our primary comparison was between rapid initiation, which we define as starting DAA therapy within 30 days of a detectable HCV RNA test, and a standard or delayed initiation. The main outcomes we measured were time to treatment, cure rate defined as SVR12, and rates of virologic failure, non-completion, and loss to follow-up. Now for our results. This first chart shows the median time from HCV diagnosis to the start of treatment, broken down by specialty and time period. The y-axis represents days. You can see a dramatic trend. Back in 2019, the median day to treatment was long for both specialties, around 400 days. However, as we move to the right, you can see a steep decline. By the 2022 to 2024 period, the median time for patient managed by ID specialists has plummeted to just 35 days. This highlights a remarkable acceleration in care delivery. This slide reinforces that finding from a different angle. Here we're looking at the proportion of patients who achieved our definition of rapid initiation. In 2019, this was a rare event with less than 7% of all patients starting this quickly. But if you look at the most recent period, 2022 to 2024, the figure just jumped to nearly 50%. Importantly, this shift was almost entirely driven by the ID specialist. While only 7% of GI-managed patients started rapidly in the middle period, over 40% of ID-managed patients did. This demonstrates a swift adoption of this rapid start model within the integrated HIV care setting. Of course, not everyone starts treatment rapidly, so we dug into the medical record to understand why. We identified several categories of barriers. First were system-related delay. There were often logistic hurdles like missed referrals or delays caused by routine 3-month follow-up schedules that weren't adapted for urgent DAA initiation. Next were patient-related factors, things like irregular clinic visit, being lost to follow-up, or transferring from another hospital. We also saw clinical management factors, such as a physician's decision to observe a low viral load before starting treatment. Finally, there are contextual constraints, like a patient being incarcerated or needing to prioritize treatment for another condition like tuberculosis. To confirm this observation statistically, we perform a multivariable logistic regression analysis to identify independent predictors of rapid initiation. After adjusting for age, we can see people whose care was managed by an ID specialist were over 3 times more likely to start treatment rapidly compared to those who managed by GI specialists. Compared to 2019, a patient diagnosed in 2022 to 2024 were 20 times more likely to receive rapid treatment. This powerfully demonstrated that combined impact of policy change and evolving clinical practice over time. So let's see the treatment outcome. Here we compare treatment outcome between the rapid initiation and delay groups. As you can see, the SEVR12 cure rate was exceptionally high in both groups, over 95%. There was no statistically significant difference in cure rate, biological failure, or treatment completion between 2 groups. When biological failure did occur, the primary cause was reinfection, accounting for 56% of cases. This high rate of reinfection brings us to the point I made earlier, the importance of curing infection quickly to reduce community transmission. In conclusion, our study demonstrated that integrating HCV care into existing HIV management programs significantly shortened the time to DAA treatment initiation. We found that ID specialists were early and effective adopters of this rapid start approach. Most importantly, this acceleration in care is both feasible and highly effective, achieving excellent SVR12 rates that are comparable to those seen with standard care. By shortening the duration of viremia, rapid DAA initiation has the clear potential to reduce HCV transmission risk within this high-priority population. Implications for practice. First, our findings strongly support the use of an integrated care model to accelerate progress toward HCV elimination goals. Second, they highlight a vital role of case managers in navigating the system and streamlining the care continuum for patients. And finally, our work suggests we can go even further. Continuous simplification of treatment requirements and support the policy changes were warranted to remove the remaining barriers and make timely, life-saving treatment accessible to all who need it. To close, I'd like to extend our sincere gratitude to the participants and their loved ones, and also thank to the entire HIV care team, including physicians, case managers, research staff, and also thanks to Professor Sun Xingyun and Professor Hong Jianqing for their guidance. Thank you for your attention.